Welcome to our 12th video in Rapid Interpretation of ECG series. Today we'll talk about the evolution of acute ischemic changes. A 55-year-old man, Mr. Rashid, arrived at the emergency department with severe chest pain radiating to his left arm. An ECG was taken immediately. At first, subtle peak T waves appeared in leads V2 to V4. Recall the criteria. T waves are considered tall only when they are greater than 2/3 of QRS length. These hyperacute T waves were the earliest sign of ischemia, caused by localized potassium leakage from ischemic myocytes. The surrounding cells were still viable, but repolarization had begun to change. 20 minutes later, another ECG was taken. Now, the ST segments in leads V2 to V4 were slightly elevated. Myocyte injury disrupted membrane ion balance, causing sodium and calcium influx and generating an injury current, pushing the ST segment upward. An hour passed, and the pain worsened. The ST elevation became more pronounced. Remember, the criteria of ST elevation is 2 small segments in chest leads. Also, the reciprocal ST depression appeared in leads 2, 3, and AVF. This happened because the infarcted area acted as an electrical sink, pulling the baseline downward in opposing leads, a classic sign of STEMI progression. A few hours later, Q waves emerged in V2 to V4. As discussed earlier, criteria of a significant Q wave is 1 small segment wide and 1 small segment deep. These deep, wide Q waves signified irreversible myocardial necrosis. Dead tissue could not conduct electrical impulses, so the initial depolarization vector was lost, leaving only unopposed signals from the opposite side of the heart, forming pathological Q waves. The ST elevation remained, but the hyperacute T waves began to flatten as the affected cells lost their ability to repolarize effectively. By the next morning, the ST segments began returning toward baseline, but T wave inversions appeared. These inverted T waves reflected delayed repolarization in the recovering ischemic myocardium. The damage was done, but healing had begun. Days later, the ECG showed deep, persistent Q waves with upright T waves. The infarcted myocardium had scarred, leaving behind permanent electrical silence where living muscle once conducted impulses. The ECG would always carry the signature of past ischemia. So, today we learned how acute ischemic changes on ECG appear, depicting underlying ischemic injury to myocytes. Let's summarize. Hyperacute T waves appear within minutes of occlusion. ST elevation follows within 20 to 30 minutes as injury currents develop. Reciprocal ST depression appears simultaneously with ST elevation in opposing leads. Q waves form after several hours as necrosis sets in. ST segments return to baseline within 12 to 24 hours as infarction completes. T wave inversion lasts days to weeks, depending on myocardial recovery. Persistent Q waves remain for a lifetime as a marker of infarcted, non-functional myocardium. Thanks for patient listening. See you in the next video.